Great. So I'm delighted to be here with you this evening and to welcome everyone firstly to this evening session and to our research study on prevention of hospital-associated VTE in psychiatric inpatients, a survey of current practice within mental health trusts in England. So this is a live session, and this offers the opportunity to pose questions and to comment via the Q&A button and the chat function. So the panel here, who have all worked on this study, would welcome discussion and questions after the presentation. We also encourage attendees to visit the poster hall, where you can view our poster on this research work. So my name is Audrey Purcell. I'm the Chief 2 Pharmacist in St. John of God Hospital in Dublin, Ireland. I've worked as a specialist mental health pharmacist for many years now, and I have a keen interest in VT risk assessment in hospitalised mental health patients, and I've published some research work in this area. With me today and welcome is Dr. Josie Jenkinson, who's a consultant psychiatrist for older adults based with Surrey and Borders Partnership NHS Trust, Vice Chair for the Faculty of Old Age Psychiatry and co-founder of the Older Adult Liaison Network. Also with us this evening and presenting, welcome to Dr. Michael Cheah, CT3 in psychiatry, based with the Psychiatric Liaison Service with Ashford and St. Peter's. So I'm now going to hand over to Michael for the next part of the presentation.
Thank you very much, Audrey. Good evening, everyone. Can everyone hear me and see the slides? Yeah. Okay, we'll carry on. So the title of our poster that we're presenting today is as Audrey described. So I'll move on to the next slide now. So move to the next slide, come on. There you go. Right, so here's a snapshot of our poster that you should be able to see on the site where you can zoom in and look in greater detail, although I will be talking through most of it during this presentation. So 2 years ago, this is more in kind of reference to how myself and actually one of our registrars, my registrar, Dr. Mohammed, who's one of the authors of our group as well, in our group, how we became involved with the work and the group. So it started with a patient story, a clinical case, a near miss. We had a 53-year-old female with a first presentation of psychotic depression, catatonia, poor oral intake, and significant weight loss in the community for months prior to her admission. And she was recommended for emergency ECT as the severity of the self-neglect was becoming life-threatening. It was very fortunate that her very first ECT session was cancelled due to low potassium levels, as she developed sudden onset chest pain the very next day, and we referred her for further medical investigations at our local acute trust. And she was diagnosed to have bilateral PE, as you can see in the CT-PA scan over here, with the red arrows pointing to the PEs bilaterally. This one is referring to a pulmonary infarct. And thankfully, she only needed the Pixaban, had no oxygen requirement, and was returned to our inpatient mental health unit just after 3 days. So Dr. Mohammed and myself, we then presented her case at our local educational academic program at Surrey and Borders. And that's how we then linked up with Dr. Jenkinson, who has been very heavily involved with spearheading the many changes and improvements for VT risk assessment and prevention in mental health and psychiatry in patients to date. We then presented at National Thrombosis Week in 2021, which is how and when we linked up with Professor Hunt, Joe Jerome, and Audrey Purcell. I'm just going to give a brief overview of VT, as I imagine everyone here has probably already knows this very well now. So VT is DVT and PE, as you can see from the diagram over here. So DVTs usually form in the deep veins of the legs and pelvis, and these can become dislodged and embolized, resulting in potentially fatal PE. 60% of all VT cases occur during admission to hospital and for up to 90 days post-discharge. And hospital-associated thrombosis, HATS, as we call it in this poster and presentation, otherwise known as HAVTE, is VT occurring during admission and for up to 90 days post-discharge. So VT is a multifactorial disorder, genetic, biological, and environmental factors, and can be broadly categorized in Virchow's triad over here. The National VT Prevention Program is focused on increasing awareness of the risks faced by patients in general hospitals, but there has been less focus on VT prevention in psychiatric inpatients, and previous NICE guidance did not specifically mention psychiatric inpatients. Psychiatric patients may be at increased risk of VT due to additional factors such as reduced mobility from sedation due to psychotropic medication, reduced mobility due to severe depression or catatonic symptoms, dehydration due to severe self-neglect, and the use of antipsychotic medication. And this diagram over here shows how antipsychotics can result in these factors, which can then increase the risk of VTE. So despite an increasing body of evidence that patients with severe mental illness are at increased risk, such as paradigmatic esteem publications like this one over here, VT risk assessment has not been embedded into psychiatric care. And data on the incidence of HAP in psychiatric inpatients, or HAVT, also appears to be difficult to access via existing data reporting systems, as shown in one of the studies that Dr. Jenkinson was involved with. The NICE guidance was updated March 2018, snapshot of it over here, which Dr. Jenkinson was on the panel for, with the recommendation that all acute psychiatric inpatients should be risk assessed for VT and bleeding on admission using a risk assessment tool such as the Department of Health tool, DOH. All patients should be reassessed during their admission if clinically indicated, and pharmacological prophylaxis should be given if indicated. However, existing Department of Health VT risk assessment tools do not include risk factors relevant to psychiatric inpatients, as you can see on this form over here. There are no specific or adaptations for mental health specified on thrombosis or possibly bleeding risk, and tools are meant to help as prompts for clinicians. So on these two over here, the middle one is one of the previous versions of the form we used in one of the older adult wards in Surrounding Borders, where there were some adaptations, such as reduced mobility for 3+ days, catatonia, and antipsychotics as risk factors for thrombosis. And on the right here, we have a VT form from Sussex, I believe, where there are also some adaptations for mental health, such as antipsychotics over here. So the aims of our study was to understand the extent that mental health trusts in England have implemented VT risk assessment in psychiatric inpatients by means of policy developments and adapted risk assessment tools, and to explore whether mental health trusts were able to provide data on the incidence of HATs or HAVTE. We did this using a Freedom of Information Act request by email, which we sent to all 71 mental health trusts in England, and we asked them a list of questions, 7 questions over here. This included whether they had a VT policy, a VT risk assessment tool was being used, and the incidence of VT in their psychiatric inpatients, and we collated their responses and analyzed them. So this table over here is essentially a summary of all the responses to the FOI, and as you can see from the inverted kind of pyramid shape, you can see it's a little bit of a table of diminishing returns. So 54 of the 71, so 76% of mental health trusts responded to the FOI, of which 4 had no psychiatric inpatients, 5 had insufficient time to reply, 3 were not subject to the FOI, which left us with 42 trusts that gave us VT information. 6 had no VT policy, and 36 had a VT policy. We'll go into details about adaptations of mental health specific adaptations for policies and risk assessment in the next slide. 3 had no VT risk assessment tool. 39 had a VT risk assessment tool, some of which are adapted, and 17 had a VT risk assessment tool, including antipsychotics as a mental health specific risk factor. Only 5 trusts out of 42, so 12% monitored VT events up to 90 days post-discharge, and 14 trusts gave us information on the number of VT events, and 4 trusts shared their monitoring policy. So on this slide here, these pie charts essentially show whether the trust had adapted their policy and risk assessment tools to mental health. So on the left, this pie chart here, 26 trusts, 72%, adapted their policies to mental health. And on this pie chart over here, 19 trusts, 49%, adapted their VT risk assessment tools for mental health. This table here is essentially a collated summary of all the various mental health adaptations of the 19 trusts that adapted their risk assessment tools. And you can see there's already quite a big variety on this list. The one commonality was that 17 out of 19 of the trusts, so 89%, included antipsychotics as a thrombosis risk factor. And then there were other interesting risk factors listed. There's some examples that, such as like NMS was listed as a thrombosis risk factor by one trust. Antidepressants was listed as a thrombosis risk factor in one trust. Another trust listed antipsychotics as a GI bleed risk factor. Several trusts listed self-injurious behavior, mutilation, laceration, trauma as bleeding risks. And there are also some additional risk factors as well, such as ligature risk, which is kind of specific to mental health patients with anti-embolism stockings. And although anti-embolism stockings are not really recommended these days. This slide here, a Venn diagram, it kind of shows essentially what we would consider to be the ideal combination of having a mental health adapted VT policy risk assessment tool and monitoring VT post-discharge for up to 90 days. And you can see that only one trust out of 54 trusts had that entire combination. And this slide here is pertaining to the final question of the FOI, which is essentially monitoring the incidence of VT recorded in psychiatric inpatients between February 2016 and February 2021, the 5-year period. And only 14 trusts, 33%, provided any information on the number of VT diagnosed in the previous 5 years. And the rest, so 28 trusts, 67% of the respondents, did not have this data available as there was no systematic approach to collecting the data. And of the 14 trusts that provided the data, the number of cases that were known ranged from 0 to 66 in the 5-year period. So in conclusion, we had a good response rate. The majority of responding mental health trusts had VT policies in place, possibly due to increased focus and awareness due to amended NICE guidance and greater focus on physical health in psychiatric inpatients, such as parity of esteem studies. There's wide variation in thromboprophylaxis practice in hospitalized psychiatric inpatients in England, and we now know that there are trusts that do not have a VT policy in place, and of course 17 that did not respond to our FOI. There are some trusts that have adapted VT risk assessment tools specifically for psychiatric inpatients, and some trusts are collecting data and have access to HAT or HAVTE incidents in psychiatric inpatients. But it's concerning that there's a general lack of access of data by most mental health trusts. Local HAT data would allow for monitoring of the effectiveness of VT prevention policies and allow comparison of incidents with inpatients in acute trust hospitals, so essentially auditing and QI, quality improvement. So the next steps, some of which we made some progress on, is to identify examples of best practice from respondents and to develop an adapted VT risk assessment tool to be used nationally for psychiatric inpatients, and to support and or conduct further research into incidence of HAT or HAVT in psychiatric inpatients and how this is monitored using existing data linkage systems, and to support the development of education and training tools around the issue of VT prevention in this group. And I suppose it's probably important to think back to the clinical stories, patient cases like the one that we described in brief earlier on. I mean, for our case, it was a near miss, so we're very fortunate because it could have happened, it could have turned out very differently. So it's important to use such cases as learning points, stepping stones to make changes and improvements to better the care, support treatment, and protect our patients better. Over here we have a YouTube link, which we also summarizes this poster. We can post this in chat if anyone would like to have a watch of it. And that brings me to the end of this presentation, which I believe would leave us a fair amount of time for some questions, if anyone would like to ask us anything.
Don't be shy, guys.
Can I ask a question? Obviously, we did this work together, but going forward, you've highlighted some of the commonalities between trusts, which did include some indicators specific to mental health. What are your plans to look to try to develop a risk assessment tool that could be tested and maybe suitable for all mental health trusts or all those who feel they could use it?
You want to take that one, Michael? Want me to chip in?
So I believe we are in the process of piloting this at Surrey and Borders, and so we've made some adjustments so far, and we're in the process of ratifying the policy and risk assessment tool to be rolled out shortly. And so we're hoping to take the lead on this.
There's lots of questions coming up in the chat. So Emma McCann, do all antipsychotics interact with VTE prophylaxis? Not sure whether you mean do they increase the risk of VTE, but yes, they do. I suspect the newer antipsychotics, such as aripiprazole, less so, but there isn't a huge amount of data about that. Dehydration risk factor for VTE in itself, I believe it is, but there may be people in the audience who know better.
And perhaps just to add to that, we've done a lot of research in terms of risk stratification with antipsychotics. It's very difficult to determine the individual risks with individual antipsychotics versus first generation, second generation. When we look at a recent meta-analysis, the evidence suggests that compared with non-users, current antipsychotic use can significantly increase the risk of VTE by about 50%. So the odds ratio in that particular meta-analysis was 1.55. But the caveat is there was high heterogeneity between the studies and sparse data. So it's important to interpret that carefully. They did do a subgroup meta-analysis on various risks with antipsychotics, individual agents, and their results indicated that there was an increased risk of VT&P observed with haloperidol, risperidone, olanzapine, and prochlorperazine, which is a phenothiazine antipsychotic actually, but not associated with chlorpromazine, quetiapine, or aripiprazole. So again, that needs to be interpreted carefully in the context of heterogeneity between the studies. Dr. Jenkinson, I had a question actually. I know you've done a huge amount of work in your trust and you've adapted the National VT Risk Assessment Tool. Did you add in antipsychotics just as a group, or did you differentiate or attempt to differentiate between individual antipsychotics?
No, just as a group, because as you say, it's too difficult at the moment to differentiate between them. And my hunch as a clinician is that newer drugs like aripiprazole that work slightly differently and have better metabolic profiles are also likely to be better, but it's not based in lots of research. But yes, in our adapted tool, we just have antipsychotic use as a risk factor on its own, and as do some of our trusts that we survey.
Great, thank you. Have we any other questions, or I can't see any other questions in the chat? Did that cover the main questions?
Can I ask Josie a question about how you're introducing this and the training you're giving to your colleagues? Because I'd imagine there's many things they have to do, and I don't know if you use digital recording or not, but what you found is perhaps the most helpful to overcome and introduce something almost brand new to the system.
So we're actually at the stage of thinking about how we could do that most effectively. We haven't done it yet. So one of the key things for me is making sure that we publish our policy at the same time as releasing a robust training program, because it's a real bugbear of mine when there are policies out there but nobody knows how to follow them. I don't think that's fair on employees. So I don't want the policy to be published until we have a robust training package ready to go out. We can get our junior doctors fairly easily via induction and academic programs. I think it's going to be more difficult accessing a wider workforce. So one option is likely to be pre-recording teaching sessions and making them available online. We haven't thought about it as part of a mandatory training yet, but perhaps that's something we need to consider.
Can I just ask one other question to you both, if you don't mind, just in terms of prompts for VT risk assessment? I know the UK tool and the Irish tool are quite different, but do you assess patients based on immobility as the prompt for VT, or would you consider, say, for example, previous history of VT as a prompt to start a risk assessment?
So it's a really good question. So immobility is the prompt, but we've had to try to design the tool very carefully so that it isn't just a case of, oh, the person's mobile, forget about it, move on. So prompts will come up, say, have you considered other factors as well, including past history, antipsychotic use, regular use, sedation, all those sorts of things, because there's a bit more complex scenario in psychiatric inpatients, I think. And there is a couple of very good questions that have just come up in the chat. So one of them is, case scenarios of VT post-inpatient mental health trust might be helpful. I can tell you the story of how this all began in just a minute, which we'll probably do in a couple of minutes, which is a great case scenario. And the other is, how about psychiatric patients refusing VT prophylaxis? This is definitely one of the barriers, but actually, you know, in mental health, one of our key skills is assessing capacity to make decisions and making best interest decisions in accordance with the Mental Capacity Act. And it is possible that there will be people who are refusing prophylaxis who are extremely high risk, and we have to do an MCA around that and treat them in their best interest. I think those cases would be very few and far between. I appreciate that many people here probably not from a mental health background. This is not something that you would be treating under the Mental Health Act. So if someone's section doesn't mean that you can give them VT prophylaxis, even if they're refusing it. It's the MCA is the relevant legislation. And capacity has to be assessed in relation to a specific decision, reviewed regularly. People have to be given every opportunity to ask questions, given the information in a way they can understand. So we would have to follow those principles in that scenario. But yes, we could give it in their best interest if they lack capacity. We discussed it with the family and it was felt clinically appropriate. I put, oh, we see patients with delirium refusing VT prophylaxis in medicals. Yes, I'm sure that's extremely common, but you just take it back to first principles of, do they have capacity? Is it in their best interest to give it? Make a decision, always discuss with the family, least restrictive approach. Unfortunately, in the acute setting, it's very hard to give the amount of time that these situations often need, but I think we could definitely do better, and that comes down to staffing, all the pressures that we face on a day-to-day basis. Quickly, because we only have 5 minutes, I can tell you the story of how this all began. Michael's nodded, you've heard it lots of times before. And I'm a consultant now, but when I was a core trainee, actually the same stage that Michael is at now, I was working on an inpatient psychiatric unit, and one of our patients hadn't been doing too well. He's in his mid-40s and very dehydrated. He was suffering from a relapse of paranoid schizophrenia. He was on high dose depot antipsychotics, that's a long acting injection, but he was also taking additional oral antipsychotics on top, which is unusual practice and reserved for when people are severely unwell. He was a long-term smoker. He had some catatonic symptoms, so was maintaining postures for a long period of time, relatively mobile, really sitting up for VTE. And one day on the ward, he dropped dead. And I went to his post-mortem because I wanted to know as soon as possible what happened to this poor man. And I remember seeing the clots in his lungs and then a giant DVT in his left calf. And it really affected me. I spent a lot of time thinking about, why hadn't we spotted that he was high risk for VTE? Why was he not on prophylaxis? He would have accepted it, I'm sure. And I did a master's project in between core and higher training and focused on that as my main project. And we basically realised that it just hadn't been identified as a relevant NICE guideline for the trust to follow. And so nobody was risk assessing anybody that came in. It just wasn't part of the culture. And also we weren't really monitoring the numbers of VTEs that were happening. But when I surveyed clinicians and spoke to them, everybody knew a case like this was something that had happened. So obviously it needed to do better. And that led on to recommendations that came up in that Royal College document that Michael mentioned earlier. And we petitioned NICE for a review of the guideline, and so we reviewed it so that it included psychiatric patients. Actually, when I interviewed NICE as part of my project, they said that, oh, it was always meant to be for psychiatric inpatients as well, but it wasn't specifically mentioned, and none of the issues specific to psychiatric inpatients had been acknowledged. So I think the current NICE guideline we have could be more in depth, but it's a start, and hopefully the next version might even be more specific as new research comes up. So hopefully that's helpful.
Great, thanks everyone. I think we've answered all the questions in the chat, or does anyone have any last minute questions for the panel? So I'd just like to thank Dr. Michael Cheah for joining us and presenting this evening, and also to Dr. Jenkinson. It's great to get the results of this research through this presentation, and also to identify next steps for research in this really important area in mental health. This talk will be available as a recording within 24 hours, and we'd be delighted if you can direct any colleagues to it that might not have been able to attend this afternoon. And if there's any other questions, or you want to contact any of the panel, please do send us an email via the send a question button in the lounge, or by actually emailing Thrombosis UK, who will share the queries with us. So thanks again for joining us this afternoon.